Welcome back to Hyperdrive Minds podcast. Robert Thomas, how are you, sir?
Doing good, man. Doing good. Glad to be on the show with you today, and hopefully can spread some insight and knowledge to the world.
Yeah. Thanks for coming on. Excited for the conversation. And we're kind of venturing outside of my typical world of like technology, sales, marketing, engineering with this one, but I'm all for helping people level up and not just their careers, but their health, their mental health, whatever it is. So I've got 1,000 questions for you because I'm like an amateur biohacker. Make sure that I'm paying attention to my longevity, trying to exercise, low carb, control my insulin, stay off
Yep.
medications and all that good stuff. But also I have vices. So I'm trying to balance all that. I'm excited about this convo. And I also see this convo as like your practice podcast before you get invited into the big leagues, right? Matt Walsh, Sean
Yeah.
Ryan, Joe Rogan. But either way, man, I'm excited to have you on. We go way back, like all the way to middle school, basically, right? We met in middle school.
Back when I had hair.
Yeah. Yeah. Back when your brother Lawson was like a chubby kid, a goofy kid. And now he's like a
Yeah.
monster.
He's two of me.
Yeah.
I still live with him in the mornings before work, and it's almost to the point now. There's such a differential in the amount of weight that we're moving and the types of lifts that we're doing. I'm like doing a bunch of old man lifts, and he's still over there doing like 335 on the bench for reps. And I'm just like, yeah, I'm gonna stay over here. I'm gonna work on my obliques.
Yeah, you'll probably, hopefully no injuries, but I like to do like higher reps now and not kill myself, right? I'm just trying to
Conscious.
avoid injury. Yeah, at all costs.
It's in your conscious psyche. You know that you got to be a dad and you got to have a job.
Exactly. Yeah, no one's coming to save me if I get hurt. You know what I mean? Especially as a solopreneur here, kind of running a business. And
I love it, man.
yeah. So let me share how we got connected. Before we do that, I did want to recognize we just lost one of our childhood heroes, and this was a few days ago, but we lost Hulk Hogan. And I just want to give him a little moment of silence here. God rest his soul. I was glad to see in some of his recent interviews, because he was on the podcast circuit for a while, and he talked a lot about his faith in Jesus. And, so I'm not worried about him one bit. I know he got baptized like in the last 2 years of his life. So I know he's in good hands, taken care of. So we met in middle school. We played football together, baseball together. And the main thing I remember is having such a great time with you and your family at the NASCAR races. And it started in Rockingham, which was close to where we grew up. And y'all were like experts in camping out for the races and so welcoming to everybody, cooking a ton of food, having a lot of games. You knew you had a system down, and y'all just welcomed a lot of us in. And I'll never forget how that made me feel. And I fell in love with your family, and you guys are such good people. And then when they shut Rockingham down, we kind of migrated to Charlotte at that point. And then we had a group of guys. There was like 10 of
Hmm.
us that would go every year and camp for like 3 or 4 days, grilling out, playing cornhole all night long, starting the day with some Dunkaroos. So, yeah, it was good times, man.
The 20-year-old versions of ourselves, if we would have been asked, will we be on a podcast, and homeowners married with children, the probability was kind of low at that point.
Yeah. I would have never thought that I'd be here. Yeah, I'm not surprised about you one bit, though. You're always smart and fun to hang out with. But I'm a dad of 3 now, running a staffing business. You're a dad of 4 and a physician's assistant and a speaker at conferences. So, man, things have changed a lot.
Yeah. It's a busy life, man. I've been cranking out being a PA now for 16 years. Started out in Troy, North Carolina, doing a lot of like rural access medicine. So that's for a PA. When you go to these rural access places, the thing is that you're typically dealing with folks, who don't have access to healthcare, they don't have access to specialty care, and going in as a PA, we're kind of trained, at least I know at Methodist University, we're trained like physicians and we're trained by physicians and surgeons. However, it's just in a 2.5 year time frame. So it's very condensed, very intense. And so when I got out of school, loans were important. and I kind of wanted to cut my teeth. So went out to Troy, started taking care of folks, learned how to grow as a provider, also just as an adult, having the responsibility of taking care of other human lives and doing the absolute best that you can. And it taught me a lot about just healthcare, how it works. It made me not afraid as a 20 some odd year old dude to pick up a phone and call a grizzly old, 25-year vet cardiologist because I have an abnormal EKG and I need help. And, we didn't have all the little nuances that we have today where we can just like scan it over, or electronically he can, hook in and take a look at the EMR. And, so it was really good. And it really helped me grow as a person and as a medical provider. But yeah, interventional pain came along, and then interventional radiology, and then being an expert consultant for a spinal cord stimulator company. And then now also doing managerial stuff as well as being a provider. So it accelerated. It started there, and then it just kind of has been going for a while. So
That's awesome, man. I'm proud of you. I was looking at your LinkedIn profile, and you got a lot of letters after your name.
I'm not a guy like, I don't define myself by that, but like when you operate in the healthcare field for a long time, it's hilarious because like when I sign off my emails and shooting emails back and forth with like the COO, all the different directors and so forth, I just sign off Rob. And then some of the folks I sign off with, I'll sit there, 10, 15 minutes sometimes, and I'll be typing into Google, trying to figure out what does that stand for? I have some people that sign their email off and it's like 3 lines of just initials. So it's kind of wild. I could definitely put a lot more, but the ones that so master's in healthcare administration, master's in medical science, certified physician assistant, and certified functional medicine provider. That's my
Okay.
abbreviations.
And I guess the most recent one was you're certified in functional medicine. So can you just walk us through, like, what's the difference in regular medicine and functional medicine?
So the biggest difference to me, one, I didn't really know about it until a few years ago. I started to really explore that. I had some patients who were going to some functional medicine providers in the area, and I was like, wow, that's pretty cool what they're doing. And in traditional medicine, when we have a patient come in and you're in the primary care setting, and they have 6, 7, 8 different chronic medical conditions, you're going into the room and you're trained. This is how you're trained. And you go in and you address, okay, you're here today for follow-up on these ticket items. And then typically the patient will bring in a few complaints with that. So you're trained to, okay, this is how we're going to manage these chronic diseases. We're going to prescribe this, order this imaging study, and get some exercise and diet, and go see a nutritionist or something. I don't know about the diet stuff. And then, so functional medicine to me was like, they're actually taking the time to identify things like nutrient deficiencies, addressing what is your exercise like, how are you sleeping, really the pillars of life, which is sleep, it's exercise, and it's nutrition. And just trying to hone in on that, very basic blanket over what we do in traditional healthcare, which is just say, you need to exercise, try to get some exercise, eat a little bit healthier, less salt, less fat, I guess. It's never really like detailed. And then this patient doesn't seem to be thriving. Metabolically, they're still unstable. I'm not really sure if they understand the nutrition side of things. And so then you send them to a dietitian or nutritionist, and that's just another provider that they have to then schedule time, go see, talk with. So anyway, that's where I was really intrigued to learn about, just a kind of a different approach, have some different tools in the tool bag to help people that I'm treating, for different metabolic problems, and, having a different set of tools to combine with what I've been trained on for the last 16 years, which is, I understand the algorithms and I understand the different pharmaceuticals that we use and the different diagnostic tools that we use and so forth. So just really add into my bag of tools to really just help people get better, live longer, and have a better quality of life, less disability.
Yeah, that was the way I was understanding it, more of a holistic approach versus just medications and surgery, right? You're looking at everything, trying to prevent instead of just medicate. And also, what's the difference in regular radiology versus interventional radiology? What does that mean?
The key difference is that so your diagnostic radiologists, they're the ones that you see in the movies and the sitcoms, and they're sitting in the dark room and it's real dark and it's real quiet. Those are your diagnostic guys. Your interventional radiology guys, we're the ones who are going out into the hospital when you have patients who are really sick in the ICU who need a central line bedside. And there are some ICU providers who can do bedside central lines, but for the most part, your interventional radiologist or a team is going to come in. We do central lines. We do PIC lines, different types of interventions that include ultrasound and fluoroscopy. And so it's a procedural driven. It's not really like my outpatient side of things is more like, you're developing relationships, you're getting to know these people for a very long time and managing them. And in interventional radiology, you're usually seeing people at the worst moments of their lives, really struggling, really fighting for their life. And so it's a different speed for me. I like that. But yeah, that's the key difference. Some diagnostic radiologists will come out of the reading room and they'll do some interventional radiology, but for the most part, it's just two separate entities. The interventional radiologists, though, when they're not doing procedures, they're typically reading studies.
Okay.
So they're doing the diagnostic stuff as well. So it's just a
Very
dual
cool.
role.
Awesome. You're involved in a company, maybe like a consultant for them. They're called Nevro, and they have a
Mhm.
AI product called HFX IQ. I think I saw on your LinkedIn like a post or something. Can you tell us more
Yeah.
about that?
Oh man, we could go an hour on that, man. Spinal cord stimulation in general has been around since about the 1960s. Actually, I think it was somewhere in the mid 60s when we did our first spinal cord stimulator trial in the U.S. And then obviously from 1964 till now, it's grown quite substantially. And there's many brands in the market of spinal cord stimulation. But spinal cord stimulation therapy, for just people who are not familiar with the medical field and what exactly that is, it's a medical device that's implanted underneath the skin and it has electrodes that are tunneled just underneath the lamina, which is the part of the spine that you can touch with your finger on your back, that sharp pointy spot. We use fluoroscopy and we guide these wires into place based on anatomy, and the device will send out small electrical signals at a certain strength and at a certain frequency. And in turn, what that does is that blockades pain signaling in the dorsal column of the spinal cord, which is where we know most of where most pain signaling occurs. So you're basically intercepting pain signals in that dorsal column, not allowing them to go into the brain in the ascending, and then also catch them again in the descending pathways. Most of them work through the ascending pathways. So it's for people who've had back surgeries, who have a lot of lower back and leg pain. It's for people who have post-operative complications like arachnoiditis. There's new indications now for patients who suffer with type 2 diabetes and have the refractory painful diabetic neuropathy, where their feet burn and tingle nonstop, and they have no sensation left in their feet. So there's probably going to be more indications that come along. Another one is complex regional pain syndrome. Nevro, it's a company that's pretty unique in the sense that they have a unique waveform that's patented by their company, and they call it high frequency stimulation. And it's a sub-threshold stimulation, so meaning that with a lot of the traditional stimulators that are on the market, they cannot go up to 10,000 kilohertz. And so what that does, though, for the patient is when you stimulate at a higher frequency, they do not feel vibrations in their spine. So with the lower frequency systems, a lot of the biggest complaints is I'm getting tired of the vibration in my back. Every time that thing goes off, it vibrates, it wakes me up, it's problematic. And then the other thing with the low frequency systems is it would make you would replace the pain that they may have been feeling in their legs, but you replaced it with like a numbness and a tingle. Sometimes they liked it being numb and tingly, and then sometimes they didn't. And so that they would maybe get tired of that, between that and the vibration. And then obviously you can't have that device on when you're driving a car. You
Right.
got to feel your legs. So Nevro came out, and it was a disruptive technology at the time, because it was the way in which you could have that device on where the patient wasn't feeling it, and they never had to deal with the numbness and tingling in their legs. They were just getting pain relief, which was unique. And so that was around 2014. And that's the one thing I will say with Nevro. They have continued to push for innovation and technology, which spinal cord stim, it was the 1990s got here, then the 2000s, and then we got to like 2004. And like I said, it was basically the same technology. There wasn't a lot of advancements in that field. And then high frequency stimulation came out and kind of was a game changer. And that's when our group in Pinehurst, where we switched over to doing the majority of our cases because we were just seeing such great results. And then in the last couple of years, what happened, Nevro knew from the beginning they were collecting all these data points, which that was a cool thing to us, because with the other companies we had utilized in the past, once this implant was placed in the patient, and whether the patient was getting great results or no results or whatever, the companies didn't typically follow up. What we noticed with Nevro is, like, from the get-go, they were following up with these people. After implant, they were checking on them and they were calling them and they were making programming advice tips, hey, you need to go to program 3 setting 4. And then they'd check on them in another week or two, and they're changing programs and they're bringing them into the office, and the technicians are meeting them, and they have all of their data saved in the technician's computer. So they know exactly what waveforms they had tried, what frequencies, what amplitudes. And so they could upload things that they haven't tried. They did that from the inception. And from that point, they were collecting all this data. Well, and good for them, they did, because then as technology advanced, and then they were the first company to come out with an AI assisted spinal cord stimulator. And what the AI system does is every day the patient has a daily questionnaire, per se, that keys up on their phone. And it typically asks, what was your pain like over the last 24 hours? How much pain medication did you take? How did you sleep? And what was your activity level? And they answer that. And as they do that over time, what essentially happens is the device gets to know them, know their patterns, make recommendations for different waveforms, amplitudes, and it's tapping in the whole time to their HFX cloud where all that data is stored. So it can, in real time, make programming adjustments where no other company is able to do that at this point. So it's totally customizable, and patients really like that because they're getting faster relief, longer relief, and if they're not getting relief, the system's working with them to get them to the settings and programs that they need.
Very cool. Yeah. That's got to be neat. And a replacement for the pain medications, right? I mean, not so much. What's the big bad wolf that everybody tries to stay away from? Fentanyl, right?
Yeah, fentanyl, Oxycontin.
Yeah.
Yeah, and that's the thing is, in 2016, 2018, that's when opioids really, that's when I think everybody as a country consensus, is like, hey, look, we got to do something different. And that's when they really cracked down on the amount of narcotics that primary care providers were writing, and they forced them to come to specialists like us to discuss their pain. And that's one of the reasons, you don't want to just continuously escalate people on opiates. We know that doesn't lead to good health outcomes and good quality of life, and their disability index actually goes up. We're trying to lower their disability index. And sometimes, now with technology and systems like Nevro, it allows us to transition these people to a technology that's implantable, and you're talking years of relief. Nobody's ever defeated a chronic neuropathic pain condition. Nobody's ever zeroed it out. And if you ever go in this is just advice, if you ever go into a doctor's office and someone tells you that they're going to cure all of your pain or this refractory neuropathic pain condition, go ahead and get out of there before you allow them to treat you. Okay. So, I mean, but because there's a lot that goes into, these people who suffer with chronic pain for, 8, 7, 10, 12, 15, 20, 30 years, whatever it is. Once these pain syndromes get ingrained, man, they're very challenging to reverse and cure. You just try to manage as best you can. And that's where, honestly, a lot of the functional medicine stuff comes into play, because once you've had pain for a long time, it changes who you are. It changes your motivations. It may even change the relationships that you have in your life. And it breaks a lot of people. And some people who are working full time, entrepreneurs, like full steam ahead dudes, and just get derailed by a chronic refractory neuropathic pain, and they've gone to all the specialists and they're just struggling, and they're taking their pills, they're doing their shots, and they're taking the ablations, and they're just not getting better. And then I've started over the last several years of my career is implementing a lot of the functional medicine things with these folks. Like, hey, let's talk about your diet. What are you eating? What is your, what are your macronutrients per day? Let's talk about, what exercise looks like for you. Let me know how you're sleeping. And that's one of the things with chronic pain patients is they don't sleep. And I'm sorry,
Wow.
man, the basic human existence, man, if you want to do anything good in life, you need sleep.
Big time.
So, yeah.
Yeah. And I can see like maybe fast forward 10, 20 years in the future, right? I can see like athletes wanting to get these implants and like the military wanting to put it in the special forces soldiers, and just like something a switch they can turn on to prevent any kind of ailments and pain, and then even further, I play this video game called Cyberpunk, and like people were getting implants and bionic arms and,
You can be the
whatever it is.
electronic version of you.
Yeah.
You'll never
Yeah.
have to die.
Right. Yeah. You never feel any pain. It's like, it just cancels it. So, dude, that's wild. I can't believe that technology exists. Very cool. So,
Yeah, the crazier stuff is going to be the implantable chips in the brain, and what they're doing with Neuralink, and what we're going to
right.
be able to do with that technology. It's going to be incredible.
Yeah. I guess they could just turn it off in your brain as well. Right. And I was like, yeah, no,
Yeah.
you're feeling a pain in your knee. All right, we'll turn that off. You still feeling that? Ding, ding, ding.
Yeah. Yeah. And then also we're going to help you to see in night vision mode now while we're hunting our enemies overseas. We don't need night vision goggles.
Yeah. We got them implanted in our eyes. The brain just turns all the light signals into infrared.
That's what Neuralink says they're going to be able to do.
Yeah, it's crazy.
You'll be able to see the world through thermal imaging.
Crazy times ahead. Just in general, as a doctor and as a physician's assistant, like who do you follow as good sources of truth these days?
I like Huberman. I like Hyman. I like Casey Means. There's several like Dr. Tina. There's a lot of podcasts, a lot of X feeds that I follow. I honestly, I'm old school a lot in the fact that I read a lot of books, because a lot of the stuff that I'm learning is new or just someone else's way of thinking on how whole systems work in the body, especially. And there's a lot of diagrams, graphs, and stuff like that with scientific evidence, and think you just want to like kind of have your hands on it and look and feel. But yeah, when I'm working out, I got a podcast rolling, I got a YouTube channel flowing. I always try to commit at least 45 minutes of my workout to learn something new, and then the last 30 minutes, when I'm feeling my age kick in, that's when the hip hop playlist or the rock and roll playlist comes on, and then I kind of power through.
Nice.
But
Yeah.
Mark Hyman, if you don't know about him, Dr. Hyman, he's a very cool guy, kind of one of the founding fathers of functional medicine, and just incredible stuff that you can do with your diet, not necessarily, taking 45 supplements a day, but just the things that you can do on a day-to-day basis that are realistic, affordable, and can make a real big difference in your health outcomes.
Yeah, I know Mark. He's a good one. And he talks about fasting and stuff like that. I've been doing intermittent fasting for a long time. I like practice OMAD, and I'm trying to do a 72-hour fast once a month. And
that's really good.
Sometimes even more. We've got this little group on WhatsApp if you want to join it called Fast Masters. But yeah, we just like, hey, anybody want to tee up a fast Sunday night after dinner? Who's in? And some people join, some people won't. But nothing's helped me more than fasting in my head,
I was reading about it, not really implementing it. And then I was like, looking at my numbers at work, productivity benchmarks that I was wanting to hit and things like that. I was like, you know what? Why do I take lunch?
Yeah.
This is about 10 years ago. And at that point, I won't say it was health motivated. It was more monetary motivation. But yeah, I cut out lunch. Really didn't, wasn't drinking all, just water through the day. And then I wasn't even thinking about it. I'm like, wow, yeah, I've been doing this now for like a decade. Like,
Yeah.
I am doing fasting. But yeah, no, so usually, yeah, I definitely think fasting, it's very good for the digestive tract more so than anything. I think giving your gut some rest, giving everything a little bit of, I always tell people, our GI system wasn't built to be like a 24/7 assembly line. We weren't supposed to be processing food and nutrients 19 hours a day,
Right.
20 hours a day. Giving that a little bit of rest might help the reflux.
Yeah, yeah, that and like the autophagy, science behind autophagy and whatnot. I'm kind of surprised that like fasting isn't recommended more by doctors, like putting people on some type of fasting regimen, or like for example, when people develop cancer, right? I think if I ever got cancer, like the first thing I would do is just go on like a 14-day fast and just try to starve it out of me. But, you don't hear doctors saying that because it's not very profitable.
Agreed. And then the other thing, getting back to the fasting, the problem is what I will say when I'm just talking about what I see in my practice, not what everyone sees in their practice, but what we're seeing, I would probably recommend fasting a lot to my patients, and I actually do. But the problem is by the time they get to somebody who even thinks about that, they're so metabolically off that they're on antihypertensives, hyperlipidemia medications. They're on things that alter their blood glucose. They're on a lot of different things that, like, if you tell somebody who's on some of those agents, hey, man, I need you to do an 18-hour fast, and they take their medications as scheduled, they're not going to feel so well, and they're going to have some pretty bad side effects. So yeah, that's a part of it. But then the other part is just you have to see 30 patients in less than 8 hours, and you don't have time to talk about the health benefits of a fast. And you tell some people to fast, and they look at you like you're cross-eyed or something. You expect me not to eat for 18 hours? Have you lost your mind?
Yeah, yeah. I try to get my mom to do it, and she's like, "What? No, I can't." And I was like, "Well, maybe it would do some good for you, but I can't." Like some people are just
Just,
not
yeah.
willing to do it at all. They think you're crazy as hell.
People are creatures of habit. And if they've been doing something in a certain way for a long time, even though if you're telling them it's leading to bad outcomes, it's still very hard for them to make a
Right.
shift.
Right. So can you talk a little bit about like how the medical community, doctors, physicians, assistants are influenced by outside factors like big pharma?
Yeah, I mean, I will talk from two different perspectives. When I was a young, impressionable provider, just not real sure about my bearings in healthcare, and you had this rep coming in who's an expert on their product, and you would listen to everything that they said, and I mean, some of the things that they would say about their products, you're like, holy cow, this is incredible. I got to put everybody on this, like everyone's getting this drug. And you get samples. And so that sometimes influences your selection because you might have a patient, who you can give them a trial of something. And it's always nice to try something before you invest in it. And yeah, they might take it for 5 to 7 days, and they might feel, whatever the feel is that you're looking for, and they're doing better. Or if it's a cholesterol drug, you give them a month's supply and they come back and their cholesterol's better, or whatever. So yeah, so you're definitely influenced. I think as you grow through the years and you get more seasoned, you get more knowledge, you get more experience. I can just speak from, for me, I learned quickly that healthcare is a business. And the business side of healthcare, there's a nasty underbelly there, but it's a business nonetheless. And then I started to really, I just didn't allow reps into the office from pharmaceutical companies after a while. That's kind of, so now there was some that I truly respected, and I thought they were doing a noble deed. But the ones who would come in and be like, "Hey, man, I notice you're prescribing this drug that's generic, and you know that it doesn't work, and you've sent in 37 prescriptions of this over the last 14 days, and I've told you that my drug is better, and why aren't you writing it?" Now, to me, like, someone does that to me one time, they're never coming back into my office. But then again, there are people who are not like me who may feel pigeonholed a little bit, or bullied a little bit into writing that prescription. I've seen it in my career. I'm not saying that that's happening. I'm just saying that I've seen that in my career. There are people who will, just to avoid a confrontation with that individual the next time they come to your office, you're just like, oh, I wrote 5 of those prescriptions. So, I mean, there are
Oh,
influences. I think like now that we have such transparency like we've never had before with the internet, with Netflix, all these docuseries and stuff like that, I think all these alternative places where people can get information, podcasts, audiobooks. I think that the world is waking up a little bit. And I think that when big pharma in general, the big pharma, I think medical providers too are very, very much more aware of it now in the last, I would say, 10 years than say in 2008.
okay. Do doctors and PAs, I mean, when you write a script for a medication that's not generic, can you make commission?
No.
No. Okay.
Mm-mm.
So there's no kickbacks, no bonus. Okay.
You might. So back in the day, the way that it used to work, well, a big drug, years ago was Crestor, and it still is. It's a great statin. But say, for instance, Rob Thomas wrote 150 prescriptions in 1 month for Crestor, and the drug rep, would be like, "Hey, Rob, do your daughters like Disney World? You know,
Uh,
I, I think I'm gonna we're gonna have a meeting, and we're gonna go to Disney World, and we got you a nice place down there for the week. Have a nice trip. Really enjoy yourself." So there was that, and that unfortunately, right as I was getting in to healthcare, that was phasing out. I would have liked a few trips to Disney World. No, I'm joking, but
yeah. I mean,
I mean,
yeah. Why not?
a few floor seats at Madison Square Garden, that's how it was when I was first getting into healthcare. And then I want to say it was the Obama administration. I want to say really cracked that down to where it went from something like that, or you're just finding bottles of booze on your desk. You know, you got like 4 handles of liquor in your office from drug reps that week, or not. I that never happened to me, but I saw it happening to providers I was working with. So it went from that, and then it went to drug reps were not even allowed to, because they used to leave all their like swag. They would leave pens and athletic bags and alarm clocks and keychain things and stuff like that. And so it went from all that to drug reps are no longer even allowed to leave a pen.
Oh, wow.
So
Good.
yeah, so the valve got kind of shut off pretty quickly.
Okay. Well, I mean, I'm glad. I mean, does the same thing apply for vaccines? Like people who might refuse those? Do you have any repercussions? Your practice would have a negative impact on your practice if you're not like giving people all the checklist of vaccines?
I'm not a person who's going to browbeat somebody into doing anything. I give them the information, to make the right decision. But at the end of the day, I still believe people have their own right to to determine their future. And there's, and I'm just here to I'm trying to be a guiding hand. I'm not here to intimidate you or make you feel stupid or peer pressure you. But no, like as far as like as long as you put, hey, certain vaccines, communicate, spoke with patient and, they declined for personal reasons, usually that suffices. No hospital or healthcare administration is going to come after you. It got kind of weird with COVID, and I really hated that happened, because I think the trust, I feel like there's always been a really good trust between providers and patients in the US. And I feel like patients were always thinking that providers, had their best interests at heart. And then, providers were put into a tough spot there with the COVID vaccines, and who needs them, who really doesn't need them, what are we seeing in the front lines, what are our colleagues seeing, what are we being told by the media that's a lie, what are we being told by the media that's the truth, just trying to tease it all out, just trying to figure it out, man. And it was a really bad time to just then, there was a lot of skepticism, and then it was like boom, here's the mandate and
Yeah.
you're going to get them. Then the media took it and ran with it. And they're telling people that if you don't get the vaccine, you're killing your neighbors. And they were just making all these they were calling people murderers who weren't getting the vaccine. And I just was like, what kind of information is that based off of? You're calling somebody a murderer. Where's the hard data where you're drawing that conclusion from, where you can sit back in front of a microphone, in front of millions and millions of people, and just say these things that were completely unfounded. There was no scientific evidence supporting it, but yet we let this narrative go. And I really think it totally eroded the fabric that we had built for decades, where medical providers and patients trusted us. And I'm not saying there's blind trust, but there's also, there's trust, and in any good relationship, you have to have it. And then now I think you took a large portion of the population, and now they're very skeptical about just basic health maintenance stuff. Now it's like, if they want to force that vaccine on me, I'm not getting my colonoscopy. I'm not letting them stick my arm and check my cholesterol. So it really eroded the fabric
Right.
of trust between the public and, medical offices.
Yeah, yeah, I know it did for me too. I started questioning because, I was like, I'm not getting it.
No,
But, I know
I'm
people
with
who
you.
did, and I don't know, man. We'll see. It's got to weigh heavy on doctors. And I know like doctors,
Yeah.
they all have their own opinions. And you go see one doctor, you might get one opinion. You go see another, and you get a completely different opinion.
Yeah.
So it's like
And
hard to tell.
the general consensus was, from my perspective, when COVID hit, I was on the interventional radiology team. And so there was a lot of central lines that needed to be placed. There was a lot of elderly people getting sick. They don't have peripheral access. We needed to mainline medications and get them hydrated. Excuse me. And so when I was treating patients in the hospital and talking to my other colleagues on the team, we were seeing most of the folks that were in the hospital they were generally sick folks. They were older. They had a lot of comorbid conditions. They weren't like the healthy Blake, with no comorbid conditions, who just, contracted COVID, and 5 days later now he's in the ICU. These were, I can't say all, the vast majority were definitely over the age of 65 and definitely dealing with multiple comorbid conditions. So right out of the gate, I started, and I always tell people, like, you don't have to be smart, you just have to pick up on patterns. And so after seeing that for the first, 3 or 4 months of the pandemic, I started to feel better. Now I was coming home, and I have at the time had 3 young daughters and a wife, and it was really scary in the beginning because I was like, God, doing my community the service that I signed up for, am I going to kill my family? I had one buddy who he slept out in a dang camper in his front yard. He slept in his camper for like literally over a month,
Oh, wow.
just because he didn't want to bring it into his house where he had 2 kids. And so, but we didn't know. In the beginning, we didn't know. So we were
Right.
all scared. We were all scared. And I would strip down in the garage and walk directly into our basement, into the shower, and scrub. And I would take my like scrubs off, and I'd bleach them. And, there was a lot of stuff. But then, like I said, I would say, honestly, for me, within the first, 4 to 6 weeks, when I was seeing the people who I was treating, I was fairly confident that this wasn't going to be a virus or a pandemic that was going to take out the human population. I knew it was going to take out a lot of people, because we unfortunately have a lot of chronically ill individuals here in the US, and advanced age individuals in the US. So I knew it was going to be a large death toll. But for me, I was like, if I get this, I'm probably not going to die. And if my daughter gets this, or my wife gets this, they're probably going to survive this. So, within a short period of time, that anxiety was gone. But still, what I never understood is, what were the people we were seeing dying with the comorbid conditions? Were they talking to the people on the front lines when they developed the parameters at which, like, these are the people who need to get the vaccine? And, they just kind of came out in a blanket statement. And I think, to me, the only thing that makes sense there is just greed, and just basically said everybody has to get it,
Yeah.
and you don't have a choice. And a lot of people were forced out of the military. I know my hospital privileges were threatened if I didn't get the vaccine, even though I was exposing myself and my family to the virus prior to the vaccine coming out, which I was like, if I'm willing to expose my family and myself to it with no vaccine, and we had no clear treatment at that time, then why should I have to take the vaccine? And they were like, well, if you like your badge to work,
Wow.
that was a pretty disheartening moment, honestly, for me. in my healthcare journey. And just, I know that a lot of my colleagues felt the same way, especially those of us who were at the front lines taking care of these people. We were exposing our families and our loved ones to this stuff before there was really any recommended treatments or vaccines. And so, it was pretty disheartening, but it is what it is. And I hope as a society and good old America, we learn from that, we grow from that, and it never happens again.
Yeah, agreed. Yeah, it was definitely a polarizing thing to go through. And yeah, I remember just like you, right? In the early days, you'd scroll TikTok or Instagram and you'd see these videos coming out of China with people walking down the street in hazmat suits, spraying chemicals everywhere. And I was like, dude, I mean, I started going to the grocery store in like completely different clothes and then bringing it and then wiping down the groceries, and it freaked me out. But that kind of faded over about a month, but yeah, just I wonder where it's
It was a lot
gonna.
of anxiety, man. I
Yeah.
mean, and I think it was, I'm not going to get into conspiracy theories, but I think there was some bad players at hand. Other than for sensationalization, why in the hell did these news media outlets run a death toll counter at the bottom of their little feed? Every one of them, they had that little death toll, and it was just, it's going like this,
Yeah.
and people are sitting there glued to their TV, like my father, who sits at home and watches MSNBC all day long, and he's sitting there and that counter's just going, and consciously maybe it doesn't make them anxious, but in their subconscious, when you're seeing the death toll, and it just heightens everybody's sympathetic nerve tone, and everybody's just heightened and anxious. I want to fight someone. I want to cry. I want to, I don't know what I want to do, but I'm just scared. So why would you do that other than to just incite a whole bunch of anxiety, a whole bunch of undue stress on a population that at the time was already stressed? And I said, so if we're going to do these death counter things, I was like, we should have one of those little numbers at the bottom of the screen. How many people are dying from eating too much sugar per day?
Oh yeah. Yeah. Why don't we count all the other deaths?
Yeah. It's like, but no, we were just trying to scare people and use scare tactics to persuade people to do what they wanted them to do.
Yeah. It's sad, man.
Live in fear. Yeah.
Yeah. Dude, we'll lighten it up a little bit. Before we were chatting and you kind of told me to look into peptides, and that's kind of in the same world as some of like the GLP-1, like the Wegovy, and what's the other one, Zempic, that people are getting on. But there's, once I watched some YouTube videos about it, like there's a whole world of peptides. I had no idea. So I appreciate you recommending that. I think that's something that you were looking to get more into, either recommending or just educating yourself more on, or educating other people on. So tell us more about this peptide journey that you've been on.
Yeah. It's honestly, I'm learning every day on them. I'm trying to educate, and I think a lot of people are, because it's a new treatment. It's a new way to combat articular, surface injury of joints, to the health of your skin, to the health of your brain, to your sexual drive. Yeah, so peptides they're coming. They're mainlining, and like you said, the GLP-1, the GIP, GLP-1 combo of tirzepatide and semaglutide. Those are the two. They're going to be the first. I think, like, I don't know where I heard this. Maybe I might be misquoting, but they said that Ozempic semaglutide is going to be the first $1 trillion drug or
Wow.
something to that. Yeah. So I think it's novel. I think it's a lot safer than some of the traditional pharmaceuticals that we're utilizing now to treat chronic disease. There's a lot of back and forth between medical providers and then regulation agencies like the FDA on just how safe these are. The problem that I see with them is right now the FDA has most of your peptides, besides the GLP-1 and GIP and a couple of others, but the majority of them, if you want to purchase them or obtain them, you got to kind of do it through the gray market.
Oh, wow.
And so you're not real sure what you're getting. And a lot of medical providers, if the FDA is not going to support it and they're going to say that it's not for human consumption and it's for veterinary use only, a lot of medical providers are just not going to, put the legal risk of doing that, because, you you may study the science and I understand the science and I know that they're likely not to cause any real harm to folks, especially. And my thing is, what's the difference between a poison and a medication? It's the dose. And so if they're used responsibly within certain parameters and boundary limits, I do think that they can improve people's health and help their quality of life and pain and all other things. But the problem being, though, like I said, when the FDA labels it for non-veterinary use, or for non-human use and for veterinary use only, well, there's going to be somebody, some lawyer somewhere who finds Rob Thomas, Mr. Peptide guy, and he's writing this guy for the BPC 157, even though there's a lot of good evidence, a lot of real world data coming out on that now, that it helps with articular surface injuries and osteoarthritic things and traumas to the joints and so forth. It's got its moniker, the Wolverine peptide, which I know you like Marvel comics and stuff like this, hence the Stormtrooper in the background. But no, and then say this individual, you made that recommendation, and then some lawyer, this guy has a reaction, and it wasn't to the peptide, it was to something else, some bad happened, and then you're going to have some lawyer out there who's going to come in and say, Mr. Rob Thomas, why were you using this? It clearly says right here by the FDA. And then you get your butt suit off and you got to pay a bunch of legal fees and fines and stuff like that. So that's a big limiting factor to it really growing. Now, there are a lot of doctors who feel like the evidence that we have now is okay. And they're fine. They're willing to stand behind the data that's being reported now, even though it's not profound. They feel like there's enough anecdotal data out there now, and they're utilizing it every day. But it's just not mainlined yet. The GLP-1, obviously, Mounjaro and the Ozempic, the reason that mainlined, obviously, is because it got the FDA approval, and then was backed by major pharmaceutical companies. But now, so yeah, I mean, the peptides, we're scratching the surface.
Right.
5 to 10 years from now, when we have this podcast again, it's gonna be a whole different climate. But yeah, I mean, there are generic manufacturers of the Ozempic and the Mounjaro out there, and a lot of these pharmacies that do it, these compounding pharmacies, essentially what they do is they add like just a small little nicotinamide, or they add in B12, and so that gets them around the patent, so they can then sell it.
Right. So it's just 10% different than the one that's patented.
Yeah.
So it's okay.
Yep.
Right. That's interesting, man. And from the podcast I was listening to, I guess that, the way you use them, some of them you would only cycle for a short period of time to see the benefit that you're looking for.
Most of them.
And then you would get off, right? It's not some drug you take forever. Right. So I'm going to dive more into that. And, I'd love to come see you one day, and
yeah,
maybe you can be my doctor, right? So
yeah,
that would be cool.
Happy to.
Yeah, man. But like a lot of people are jumping on the Ozempic and that kind of bandwagon and losing a bunch of weight and all this stuff. But I see a bunch of horror stories out there about people having negative impacts that like pretty much like seizes their gut and gives them all these other ailments and whatnot. And I guess, the way that you have to use them, if you're not using them correctly, you can see a lot of negative impacts. Like if you, maybe it's suppressing your appetite, so you're not eating, but that makes you also nutrient deficient. And so you're going to bring on a lot of other problems for yourself. And then, so it's like this balance you got to keep, right? You got to make sure you're getting enough protein, enough fat, and nutrients so that you're get the benefit from them. Otherwise, it's going to cause more problems than it's worth, right? I mean, what are you seeing out there with some of these like medications like that?
There's a couple of camps out there on this topic. I believe that they are a wonderful therapy for the right individual. The problem is you can't just take somebody who's metabolically unstable. And what I mean, somebody who is a totally uncontrolled, unmanaged individual who's non-compliant with most of their therapies, and they're really sick, the internal terrain, I would say you got to get the internal terrain you got to start curbing that a little bit before you introduce a lot of these agents. But if you get somebody and you get them with the right internal terrain, a lot of people aren't doing that. They're just, you're coming in, there's a lot of barriers to it. Insurance companies don't want to pay for it in a lot of instances. People need to lose weight, but because their A1C isn't high enough, they can't get it through their insurance. So they're going to these med spa places with guys who went to a weekend course, and they're just like, hey, yeah, you need 2.5 milligrams, and then we're going to get you here. And then you come back a month, we're going to get you there and here and there and here. And there's no monitoring parameters that are really going on other than, basic lab panels like, okay, your kidneys are not failing and your liver seems to be hanging in there. Keep going, So you got a lot of players, a lot of variabilities there. And you really need a provider who truly understands how these medications work, number one. And you got to have a provider who's willing to take the time with you to set up your nutrition, to set up, you have to be weightlifting, you have to be exercising during this time. Otherwise, yes, you're going to lose weight. We know that. But when you're losing all this visceral fat and you're losing all this adipose tissue, you want to be replacing it with dense muscle mass. You don't want to have these gaunt looking individuals who've lost a substantial amount of weight in a relatively short period of time, and they have, literally like zero lean muscle mass on their body. Yes, they may be less body mass, but they're still highly disabled, and a lot of times in a lot of pain and a lot of discomfort, and just they may be even sicker afterwards. So it's just, you got to pair it up, and you got to get individuals who are motivated and want to make the change in their lives, because like you said, nobody's going to take a GLP-1 forever. I mean, I might eat crow on that in a few years when they microdose, GLP-1s, and it's the new fluoride in our water supply, But no, but I mean, you could, I guess, you could microdose GLP-1 for the rest of your life if you want to. There's no data out there on that. I mean, go for it if you want to. But I always get back to, you can't do that forever. You're not going to be able to take, 5 milligrams of Mounjaro for the rest of your life. So you have to marry the right patient, the right dose, with the right provider, doing the right monitoring, and you're monitoring the visceral fat, you're monitoring lean muscle mass, you're making sure that they're nutritionally making the changes that are necessary at the end to be healthier, right?
Right.
To have lower disability, to improve their overall longevity, and make life
Yeah.
a little better.
It's all about the longevity. So I guess the biggest problem with it is like the weight that people think they're losing in fat. A lot of times, like majority of it may actually be their bone density and their muscles, which you don't want to lose any of. So it's like you don't realize the damage that they're doing. Yeah, you look a little better in the mirror, but inside it's bad.
Questionable. I know my brother Dan, he likes a thicker chick. I'm joking.
Dan.
No, but the thing is that everybody always wants the easy, right? There's no easy path to a healthy lifestyle, and there's never gonna be one. It's about your effort, and it's about your willingness to change and to identify that you need corrective behaviors built in. You need to break down everything that you are doing because it's leading to poor outcomes. I can't tell you how many patients I've had come in, and I'm like, oh, hey, Mrs. So-and-so, how are you? Oh, wow, yeah, you've lost like 90 pounds. And she's like, yeah, I've been on that the semaglutide, and I've been so nauseated for like 9 months. But she's like, and the only thing that I can tolerate is cheesecake. So I eat 2 pieces of cheesecake a day, and I've lost all this weight. It's been the greatest diet of all time. And I'm
My
like,
God.
I'm sitting there, I'm like, oh boy.
This ain't
My
good.
God. All right, we're gonna get a bone density test here, stat.
Oh my God.
And I'm like,
wow.
I'm like, what? I was like, what did your primary care provider, or what did that, med spa person say? They said, keep going. You're losing weight. You're doing great. And I'm like, oh God.
Oh my God. There's going to be some class action lawsuits in the future, I feel like.
And honestly, it's on the provider, man. It's on the provider for not educating themselves on the appropriate monitoring parameters at which they should be telling these people how to utilize this medication. And that's patient ownership. It's the provider. So it's multifactorial, but I can't tell you how many times in the last like 3 or 4 years I've had patients come in and they have this profound amount of weight loss. It's been great. I have been eating nothing but Chex Mix. That's all I can tolerate. I've ate Chex Mix every day for 9 months and I am down 100 pounds. And I'm like, holy hell. And like, we're going to see scurvy come in. We haven't had scurvy since like the 1700s, man.
That sounds insane to me. Like common sense would just suggest like that's not a good habit to get into.
You would be shocked, man,
I
at
bet.
just the disconnect of nutrition to what you're putting in your mouth, then your health outcomes. The American, for whatever reason, it's been like it's deprogrammed. Like it's shocking to me like how many people like can't understand that a Bojangles biscuit and 18 ounces or 20 ounces of sweet tea every morning, like why is that bad? Like what it tastes good. My grandpa did it, my uncles did it, and I'm doing it, and look at me. Like I don't like what's wrong with that? There's nothing wrong with that. And it's like, no, everything is wrong with that.
Yeah, that's the worst
And
thing you could put in your body.
it's just crazy though, the disconnect that people have with what goes in here and then their health outcomes, their bone density, all these things. So
Yeah. We need to go back to, probably just the education system itself needs to put more weight on nutrition as something that a class that you take every year, even starting in elementary school, like good eating habits. It just all falls back into people. They just don't know, right? They don't know. They're ignorant to it. They're not seeking out information.
and that's the thing is, our system is set up to be reactionary. It makes the most money that way. But, that's the thing is like you have to understand, like, folks, you got to work upstream of the problems to divert a disaster down the road. Most of what we do in healthcare now is we get the downstream problems and we just stabilize them. Maybe we can make a few of them better, but we're just stabilizing. The thing is with our advancements with medicine, we could take a really, 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 really sick 65-year-old and we could survive them with modern surgery and medications to 80, 85 easy. Now, is there quality to their life? Not that much. Is their disability rating extremely high? Yes. Are they enjoying life? No. And dealing with lots of psychiatric problems, from that. And so it's like, yes, you survived to 85, but the last 20 years of your life were miserable.
Right.
You're in a miserable state of health. Yeah, you were alive and you were able to take pictures at your grandkids' birthday parties, but like you were there for an hour and you had to go home because you were in so much pain. So, yeah.
Yeah. Well, we all have our vices. And, even though I'm into fasting and OMAD or whatever, I still love Cheez Its. I still like Doritos, Chick-fil-A
Yeah.
every once in a while, even though there's like 60 ingredients in a chicken sandwich, like 50 of them are
It's
unnecessary. It's
really good
still
though.
crazy. Yeah, really good. And,
Really good.
alcohol, really good.
Uh-huh. Yep.
I got into these things. I should have never got into the
Oh
nicotine
man.
little pouches, but all the biohackers are big on the
Those are game
nicotine.
changers, man.
Yeah, yeah. I like them, right? I try to limit them to like
Yep.
one after coffee, one in a big meeting, and then if I'm playing video games at night, I'll throw one in because I think it makes me play better or whatever. But,
Yeah,
still, I've
definitely.
noticed you got to be careful with them because I think they do have an impact on your hypertension and your heart rate, right? So if let's say I have a big like a high carb dinner, pasta or pizza or something like that, and that's my meal for the day. If I go and take a nicotine pouch after that, it's almost like the inflammation is so much in my body, and then the
Hmm.
hypertension's already there, and then the nicotine has its impact on
It's
that,
a
and
it's a va- it, yeah.
it gets
It's
uncomfortable. I have to
vasoconstrictor.
take it out. Yeah, I feel it. I have to take it out. So
Hmm.
it's definitely it puts people at risk for other things they don't realize.
Yeah, my wife, she doesn't like my Zen. She thinks it's bad, but I'm actually seeing more and more patients come in, and they're actually wearing nicotine patches for that very reason.
Oh, wow.
for the nootropic effects of it to help increase their concentration, their mental acuity, and things like that. And they note it. They say it helps. So again, it's what's the difference, between a medicine and a poison? It's the dose. And so I have friends who go through 3 cans of Zyn a day. That's
Holy,
probably really bad. That's a lot of nicotine, and I
a
don't
lot.
know how much mental acuity you're getting, but you
There's
don't need that
diminishing
much.
returns from it, I can
There's
tell you.
diminishing returns, absolutely. The biggest thing is, folks who use nicotine, if you have a bunch of calcified arteries, veins, you're hypertensive or you got a high calcium burden or whatever. Yeah, that vasoconstriction that the nicotine causes, can elevate, blood pressure even further. Definitely, I wouldn't say it's the best thing in the world to do,
Super
you know,
habitually. Yeah.
yeah, yeah. There's always those boundary limits you got to find to operate in. Just don't drink the whole fifth of bourbon and maybe have 2 to 4 ounces, right?
Right.
Uh,
Everything in moderation there.
yeah.
Yeah, I'm trying to limit my caffeine too, right? So people digest and process caffeine a lot differently from one person to the next. And I know it's got like this 10-hour half-life, so you got to be careful not to drink it all day. Are
hmm
you a coffee guy?
So my day, yeah, I mean, I like, don't get me wrong, I like coffee, but I don't do coffee routinely. I'm a pre-workout guy. Before I go into, I usually get up early, around 4:45, 5 o'clock in the
Holy.
morning, and go work out. So to get going that early in the morning, I have my Greek yogurt, my blueberries, my chia seed, and my pre-workout drink.
That's the routine, eh?
And yeah, and then I go work out. So yeah, no, I'm not a coffee guy, but yeah, no, definitely regulating your caffeine intake. Again, it's you can just get diminished returns. Like I still like when I have a cup of coffee, I still like to feel that, like boom, all right, I got some energy, I'm focused, let's go. I have patients who drink up 3 pots of coffee a day, and they can't understand why they're peeing all the time,
And can't sleep.
can't sleep, peeing all the time, and I got the worst reflux of my life. Like I have to take like a bottle of Tums a day. And that's the one thing about caffeine. It's an irritant to the gastric lining. So that can, and anybody who has reflux disease or you
Gas
know
or whatever.
yeah, whatever they call it. Yeah, I've it's so many. It's so
Heartburn.
funny. Yeah, there you go. Thank you. But there's so many ways that people describe their symptoms. It's quite entertaining sometimes. Caffeine's definitely one of those substances that's abundantly abused here in our country. I think it has to do with the cloth of our society, and we're Americans are hard workers. We charge hard, we work hard, and we play hard. And I got a lot of guys that I know, real good dudes, just maybe not the most educated on nutrition and dieting and things like that, and they're showing up, working those factory jobs, but they're drinking through their day over 40 ounces of Monster. And then they're like going to the doc and they're like, I'm hypertensive, I got blood sugar issues, and I'm having palpitations in my chest. And they don't draw the correlation between the massive amounts of caffeine they're dumping into their body during an 18-hour day that they're awake, and the symptoms that they're manifesting. And those energy drinks, man, I can't tell you how many patients that I've had who have these super aggressive cardiac workups, and nobody's even questioned, like how much caffeine are you consuming a day? And getting a truthful answer from the patient is the other half of that coin.
Yeah.
Those Monster energy drinks, I think they come in like 60-ounce cans now.
Oh my
It's
God.
great.
Yeah, it's not just caffeine with those, right? It's all the other, it's like taurine and ginseng and all these other things that like
Yeah.
amp it up even
Yeah,
further.
yeah. Well, taurine's actually a good supplemental element to have, but yeah, it's just honestly, it's all the sugar. It's all the sugar and it's all the caffeine.
Yeah, yeah. And probably a little bit of alcohol as well. So where's science at these days with, the okay amount of alcohol to drink? 'Cause I know it used to be like 14 a week or something like that, and then they made it 2 a week. That's okay. And now it's almost gone to 0.
Yeah, I don't like to fill out those alcohol questionnaires in the healthcare field because it tells me I need to go see a behavioral health specialist. There's back and forth on, like I had a lady the other day, and this is just how I think common sense goes a long way in life, and you don't have to have 15 abbreviations after your name to be smart. People who have, pattern recognition and good common sense go far. And this lady, she went to her doctor And her doctor just basically like made her feel like she was an alcoholic because she was drinking maybe a glass to 2 glasses of red wine 5 to 6 nights a week. And the doc was just like, you're an alcoholic essentially, and you have a problem and you're using it as a crutch because your husband died, and kind of didn't take a minute to step back and think about what she was saying other than just identifying the amount of alcoholic beverages she was consuming. So the lady was like, and she's a very nice lady, like a former flight attendant and actually healthy lady. Like she really didn't have a whole bunch of comorbid conditions. She was like 72, and like that was her only vice left in life, right?
Right.
Her husband's gone. He died tragically, stage 4 cancer, and she liked having, not every night, but 6 nights, 5 nights a week, she was having maybe 1 or 2 glasses of red wine, and that was her thing. And her primary doctor made her feel so bad that she gave it up, and so she quit. And then she's eating 2 fudgesicles now every night. Went back and reported that to her primary care physician, who then told her, it was like, okay, I'm glad you gave up the alcohol. And I'm sitting there thinking to myself, I'm pretty sure that those 2 fudgesicle ice pops that she's eating at nighttime are doing far more damage to her health than the 2 glasses of red wine. And
Yeah.
then
Wow.
there are studies that do suggest, the antioxidative components of the red wine is actually cardioprotective. Yeah, I mean, obviously don't drink the whole bottle, but I mean, if you're having, 4 to 6 ounces of of red wine at night, okay, it's better than 2 fudgesicles.
You just replace one bad
I mean,
habit with another. Yeah.
yeah,
Even
you did. I mean, you didn't even go to med school, and you could probably identify that, right?
yeah, yeah. Well, I've just listened enough of the podcast. I know it's a constant battle against
Hey,
insulin, right? Regulating
yeah,
insulin. That's
yep.
the battle. What kind of supplements do you take? I know you said you do the pre-workout stuff. Do you take anything else personally?
Yeah, I honestly do a good men's multivitamin. It's actually 2 tablets a day. And then I have basic chain amino acid I take on the days that I work out, have a post workout recovery protein, and then pre workout. So I'm not one of those guys who takes like a handful of supplements. I try my best. I think the key in life is trying to dietarily, push yourself to make, eat like you're eating for your health, for your well-being, for your longevity. So I think the key metrics, and this is Rob Thomas. Now, this is not a documented study, but I think that my targets every day are trying to eat, 30 grams of fiber, and that's chewed fiber, and usually in the form of broccoli, cauliflower, Brussels sprouts, avocados, kale, spinach, and beets. Try to eat a lot of beans. Try to eat a lot of legumes, nuts, and that's where I try to get like all the fiber from, because you're going to get a lot of the good things that you're going to get through a lot of these supplements that people take every day. Protein, everybody's like super high on the protein right now, and getting the protein that intake is relatively easy because there's just so many different options for protein that are good sources. So, but yeah, so I'm not a big supplement guy. I don't take a ton. I have some friends that take quite a few, and that's
Yeah.
fine. If I always say, hey, if you're feeling better, you're having more, you feel more alive, you feel, like you concentrate better, your sex life is better, what, great, I'm happy for you. Because there's a lot of
Yeah,
them
yeah.
out there, man, and it can get confusing. So
Yeah, there's too many.
yeah, yeah, there's way too many. And then what I find is I'll have people bring in all their supplements, and they don't even realize the redundancy that they have in the different supplements that they're taking throughout the day. And the sad thing is a lot of it's coming from these supposed wellness providers.
Yeah. Yeah, it's kind of hard. I mean, there's so much out there. It's hard to even zoom into the truth. The one thing that I've discovered this fasting thing, and through that, I've understand the importance of electrolytes. So that's one of the main things I try to get in, because I know, coffee will deplete electrolytes, and carbs, spend more of your electrolytes to process than they actually give you. And then if you look at how many, how much electrolytes your body needs to function properly, and the minerals and trace minerals and all that,
Hmm.
so if you can at least feed your body those,
Yeah.
I think that's like the bare minimum, get the electrolytes and the trace minerals, and then go from there.
No, I mean, and that's great. I mean, and you're a young man and you have two wonderful functioning kidneys that will help you with your electrolyte balance in the body and your pH, and keep you thriving and keep your brain healthy. And your well balanced diet is also going to be, a key source. I have so many patients through the years who are obsessed with electrolytes, or they think like electrolytes are going to give them energy. And what's the number one form of way people consume electrolytes in the United States? It's freaking Gatorade, man. And
Yeah.
Gatorade is wonderful. I love Gatorade. When I'm running and I have another mile and a half to go and I need some energy quick because I want to finish in 10 minutes, I chug a lot of Gatorade, and it helps to refuel my muscles so I can push to the finish line. However, there's a large demographic of folks who drink Gatorade as their main form of hydration day in and day out. And it is overloading their body and way too much sodium and way too much sugar. And it leads to obesity, which then leads to insulin resistance, which then eventually will lead to the wonderful type 2 diabetes and other metabolic dysfunctions that we're dealing with.
Yeah, people just choose the worst option possible. Like they think that something's going to help. It's like, wait a minute, did you look at the sugar? Like you didn't notice?
Uh,
Like you got to get the sugar-free kind. Oh God,
No,
it's crazy.
yeah, and but I mean, it's subliminal messaging. They grew up watching TV and they see Michael Jordan chugging that Gatorade, and who doesn't want to
Yeah,
be like
it's
Mike?
got to be good. Got to be
Yeah.
good for you, man. What time do you go to bed if you exercise that early?
That is the one thing I have to work on. I need to be in bed by 9 o'clock, but most nights I'm doing stuff, with, my current job.
Oh,
I'm trying to start a business. So there's always something
we
to
lost him.
do. And so I try my best to be in bed no later than 10 p.m.
Yeah.
So I need to get better at that, definitely for my brain function as
Yeah,
I get
same for me.
older.
I don't want to go to bed and I don't want to get up, and it's like a curmudgeon for both. But yeah, and then video games don't help. Playing video games, like, oh man, I need a 10:30 rule, but I don't get up as early as you. I set my alarm for 6:30, and I work out in the middle of the day or towards the in the afternoon at some point. I kind of move that around. I can't stay on the track of exercising early in the morning. I can do it temporarily, but I always like I'll just lose steam on it. It won't, something will throw me off. Kudos to you if you can really be consistent about that. That takes so much self-discipline and self-control that you're on another level.
Well, trust me, I would totally prefer to work out midday. I feel like I'm stronger and better then.
I think you're right. You do have a little more energy at lunch or in the afternoon. The workouts there, you feel a little bit more roaring to go. You got a little bit more strength. But I think there's benefit, a little bit more benefit to doing it in the morning, and it helps you throughout the day. So it's definitely the best way to do it, I think.
I would agree. Yeah, I can not just looking at studies and stuff like that, but I can tell the days that I work out before work, I have more elasticity in my mind to deal with you have your day planned and then this happens and then that happens and you get behind and they have an add on here and you got to get to the credentialing meeting there. And the days that I work out, I feel like, yeah, I'm ready. I'm ready for everything. And then there are days that, I don't work out and I can feel my anxiety levels are much higher. I'm having a harder time staying focused. My energy levels are a little bit lower. So yeah, for me, it definitely helps my performance through the day with the multiple hats that I wear.
Well, if I ever get back on the early morning workout train, I'll let you know. Maybe you can text me and
I'll
you know,
send you motivational quotes. That's what
yeah.
I'm good at that.
Yeah. All right. Deal. But you mentioned performance. So that's one other thing I wanted to ask you about because, especially in the male driven like podcast scene, the biohackers talking about microdosing or just dosing a little bit of testosterone, getting like testosterone therapy. I know you lose a lot of testosterone as you get older. So what's your opinion on doing that? Is it a good idea? You got to be careful with it or stay away from it if you can.
Yes, I think it's a good thing. So start out with that. But if you come to me, I'm like, okay, this guy's in good shape. He's, say this is, you're 55 and you're noticing your energy, your concentration, but you're in pretty good shape. You're trying to do all the things that you can do on your own. And you're like, I'd like to try a testosterone supplement. And you're relatively a healthy guy. And yeah, we check your T scores and you're down around 300, and we maybe want to move it up to around 600 and then see how you feel there. That's totally fine, and I think I think most of your medical establishment will agree with that. The problem is if you have just like a really, like obese guy, sedentary, maybe he doesn't have a ton of metabolic disease. He doesn't have the type 2 diabetes, the hypertension, the coronary artery disease, the congestive heart failure, but you just know he's really just sick. He's not very healthy. The first thing I'm going to do with those folks is going to be like, all right, hey, here we go. Let's talk about, these are the nutritional things that I need you doing. I need you to start losing weight, because let's face it, adipose tissue for men acts like an ovary. It's just, you have an ovary. It's the adipose tissue. And so if you start losing some of that adipose tissue, your testosterone levels will go on their own. And that's just making simple changes. I don't believe in these people who are really unhealthy and then you don't really change anything about their lifestyle. And then you pump them full of testosterone. And there are side effects to that. And one of the scariest things is polycythemia, where you thicken someone's blood so much that you have, major end organ damage event occur, and that could result in a heart attack, a stroke, death.
Oh, wow.
Yeah. So you got to be careful.
Is it true that your body will stop making testosterone if you take it, and then if you get off, it may not ever make it again? So you kind of get stuck on it forever.
Yes. And that's the other reality. So, and it just depends on how you're dosing it. And then again, it also depends on the internal terrain. And I mentioned that earlier in our discussion, what's going on internally in that individual. But yes.
Okay. Yeah, that's kind of why I want to do it, but I also want to avoid it because, I don't really have any problems, right? And then fasting also, from what I understand, if you fast for long enough, it really jacks up your testosterone levels, so that helps.
Look up Tongkat Ali.
Okay. Yeah, it's like a natural supplement to boost it. Yeah.
Yeah, go for it.
Tongkat Ali. Yeah. Very cool, man. Well, I have learned a ton, Rob. Thank you for coming on. This has been an interesting convo. It's good to see you. Good to spend some time with you. And I hope everybody has learned a little something from this. Do you have any last remarks? Anything you want to leave with the audience before we wrap?
No, man. I just, you intrigued me with all of your funny Facebook posts, and I was like, man, I love what Blake's doing, man. It gives me a laugh throughout the day. I think your content's really good, man.
Thank you. Yeah, I appreciate that. It means a lot to me.
Yeah, and I watched a few of your podcast or YouTube channel videos, and I was like, hey, you know what? That would be a good thing to do, and maybe I'll reach out and talk to my old buddy. Me and my wife, we're starting a functional medicine / concierge / aesthetics practice here in Pinehurst. Thomas Medical will be opening our doors to our practice hopefully around October 7th. That's our target, is to be open. We'd love to see you. You can tell all your followers to come see us at Thomas Medical. We'd love to have them and get them healthier, living longer, using the best practices of traditional medicine, combining that with functional medicine and some of the newer technologies like peptide therapies and so forth to help them live the longest, best, happiest quality of life possible. So you can go to our website. We haven't launched it yet. We're almost ready to launch it, and it'll probably be in the next week or two, but it'll be it's www.thomasmedicalnc.com. Follow us. We're going to have a Twitter, X, Instagram, Facebook, Thomas Medical NC. So
love it. Yeah, we'll link that in the description for you. Man, I've enjoyed it. You've been a good guest. We can do it again sometime. We can make some more content. So it'd be fun.
Yeah, we'll find some new healthcare topics that'll come up, and I'm happy to help. But I'd love to do it, man.
All right, brother. Well, hey, appreciate it, and have a good rest of your evening, my friend.
All right, peace, brother. Good to see you, man.